Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to the latest episode of Talking Meds. I'm delighted to be joined today by two wonderful guests, Professor Anna Murphy and Ravijyot Saggu, two talented and eminent pharmacists who work in the field of respiratory disease. We're going to discuss the latest update to the asthma guideline from NICE. And of course, this is quite a milestone because for the first time, and not before time, quite frankly, this integrates NICE, BTS and SIGN guidance and was done as a collaboration between those three organisations. So we're going to discuss what the main highlights of the update is for medicines teams and prescribers and discuss some of the challenges that may arise when we're implementing these recommendations, particularly around the person-centred approach that's needed and maybe some of the sustainability implications as well. So Anna is a professor of pharmacy practice at DeMontfort University and a consultant respiratory pharmacist for University Hospitals of Leicester. She has over 25 years experience working in the field of respiratory medicine and sits on several national committees, most notably on the BTS Council as co-chair of the Medicines Optimisation Working Group of the Taskforce for Lung Health and a member of the NHSE Inhaler Working Group. She's published widely in peer-reviewed journals and she's the author of the Asthma in Focus and produced the 7 Steps to Success Inhaler education materials as well. Delighted to have you here, Anna. Ravijyot has a background as a hospital pharmacist and she's an honorary clinical lecturer for the London School of Pharmacy at UCL. I first came across Ravijyot when she was the Chief Pharmaceutical Officer's Clinical Fellow in 2021-22 and I was deeply impressed with her passion for person-centred care. She's chair of the UK CPA Respiratory Committee and has been part of the NICE, BTS and European Respiratory Society Guideline Development Committees. She's a coach as well as a NICE associate and is passionate about sustainable, personalised and holistic care for patients, population health and integrated care to reduce health inequalities. Delighted to have you both here. Did I miss anything there, guys? Anna or Ravijyot, is there anything else you'd like to highlight about your career? I guess in particular what I'm interested in, what is it that makes you passionate about working in respiratory disease? Anna, what is it about respiratory disease for you?
Well, like you said, Jonathan, I've been working in respiratory disease for over 25 years. So there must be something here that sort of kept me going. And it's just very much, I love respiratory because you go from paediatrics all the way up to the care of the elderly. You've got, it's not just asthma and COPD, which everyone thinks sort of respiratory disease is. We've also got cystic fibrosis, bronchiectasis, fungal disease, interstitial lung diseases. And so there's a real scope as a pharmacist, I feel, to get involved in true patient care. And I think the patients are also very, very responsive and receptive to anything that we can do as pharmacists to improve their care. And of course, medicines are just vital in controlling these patients and controlling these conditions. So for me, I think my work in the 25 years, I've not just been hospital, I've worked in primary care, GP practice, clinics, domiciliary visits over to COPD patients, as well as working in the acute and tertiary care that I also work in now. So, I think it gives opportunities for pharmacists, and that's why I'm very passionate about it. And it's all about the patient to me.
Brilliant. I mean, when I worked as a clinical pharmacist, I used to love doing asthma clinics and seeing patients with COPD. And sometimes you can get a real sort of sense of helping them as well, because the treatments can be very effective when used correctly. But of course, pharmacists have a really important role there for sort of making sure that inhaler technique is correct and all the rest of it. What about you, Ravijyot? What was it that made you passionate about respiratory disease?
Hi, Jonathan. Yeah, same as Anna. It's pretty much that we can make such an intervention, whether it's with medicines or without. And I really love the aspects of holistic care and really person-centered for patients. And just yesterday, I had a lovely email from a patient telling me how the interventions and support has really been able to make a difference for his asthma. So it's really nice when you can see that a lot of the input that we have can make a real difference to patients, and some of the harm is preventable. So I think there's a lot of good that we can do with medicines, and it's about how we support the patients to get the best out of that. So And that's what's kept me in respiratory also for over 20 years as well.
Brilliant. Yeah, no, I think I really get that, really understand that. I think one of the things you said, Anna, as well, was it affects people of all ages as well. Lots of diseases just affect maybe a particular age of population, don't they? Maybe it's elderly or maybe just children, but respiratory disease affects everyone. You see children with brittle asthma, and you see older people with asthma, COPD as well. So it's the whole of the population that's involved here.
And I think as a pharmacist, Jonathan, I think, sorry to come in on that, but I think that's really important because wherever you work as a pharmacist, whichever sort of line of practice, you will come across patients with respiratory disease, and there's always something that you can do to contribute to their care and provide that sort of patient-centered care that Ravijyot sort of talked about there. So it's very, really important.
Okay, so as I said right at the start, the big news story in asthma is the update to the NICE guideline on the management of chronic asthma, and for the first time, it's also incorporates the BTS SIGN guideline as well, which is great news because we don't now have different guidelines that potentially say slightly different things. So, Anna, Ravijyot, for you, what are the big changes to the guideline?
I mean, I think there's two main changes. One is around the diagnosis of asthma, which I can discuss, but also around obviously the prescribing. And for any sort of newly diagnosed adolescent or adult over the age of 12 years, or 12 years and older, should I say, we are now sort of removing the initiation of inhaled corticosteroids on its own and starting patients on low dose inhaled corticosteroid in combination with formoterol. So formoterol is a very quick acting, very similar to salbutamol, but also a long acting beta-2 agonist. And the plan is that we will provide this to patients and they will use it initially if they've got very mild asthma, just one dose when they need it, so one dose PRN. If they have more sort of sustained symptoms, then they would start on the MART therapy, which some people are probably much more familiar with, which is the maintenance and reliever therapy, where patients will use the same inhaler, the ICS plus the formoterol, in the morning and in the evening, but then we'll also use that when required throughout the day. So we're basically abolishing and removing from prescriptions short-acting beta-2 agonists, so salbutamol and terbutaline.
So it's interesting. So for a number of years, we've known that there is a potential issue with people who are prescribed SABA, short-acting bronchodilators, on their own. And in fact, there's been quality improvement measures looking at the number of blue inhalers that have been prescribed in relation to the brown inhalers. So this doesn't come as a massive surprise, does it? There's been European and world guidelines for a while that says use of short-acting bronchodilators on their own is potentially associated with harm. This changes that quite significantly, doesn't it?
Oh, absolutely. And we've actually known this since the 1970s, Jonathan, when, some of the more very specific beta-2 agonists like isoprenaline was launched in New Zealand. We saw an increase in deaths, and we know from labbers using them without ICS, so there's an increased risk. The MHRA has got guidance on that. So we've known that actually short-acting, long-acting beta-2 agonists without inhaled corticosteroids is detrimental to our patients.
Yeah, I mean, I guess we can come back later to the implementation challenges, but just on this, how much of an implementation challenge do you think this is? Do you think people are already doing this routinely anyway? Or do you think for some people this will represent a change in their practice?
I mean, from my perspective, it's very much, I think this is quite a big change in practice. I think, for our patients as well as for our healthcare professionals in terms of prescribing. Patients are very over-reliant often on salbutamol, as you've already said, Jonathan, and prescribers, it's quite a change. We've had MART for many years, that's been licensed for many years, but it's not really been utilised as much as it should have been. So this is quite a big change for prescribers across the system to take on board.
Yeah, I agree with Anna. So, I mean, the guidelines are different, and like Anna has said, there's two key changes there around the diagnosis and the treatment there. But actually, the move is welcomed. It's a simpler pathway, and there's more of a pragmatic approach to how we're implementing this and treating. And one of the things which is quite welcome is there's an explicit line within the guideline that says that there's be no SABA prescription without concomitant inhaled corticosteroid and ICS. As well. So, I mean, the guideline are really emphasising the importance of good history taking so that we can support that with objective tests to rule asthma in or out as well. So, as mentioned, you've got these kind of ICS LABA in one combination inhaler as your main inhaler, and for most people that will be the correct approach. And there's two parts to that. So either milder asthma where you're using that in the air regime, which is the anti-inflammatory reliever, or the MART, which is the maintenance and reliever therapy as well. So it's making it easier to remember that you've got one product, and there may be a few products which are off license as well, but it's one inhaler. So that should be less prescribing of SABA, which we hope to see as well.
Yeah, no, that's really interesting. I mean, NICE don't often make do not do recommendations, but recommendation 1.63, as you say, Ravijyot, is do not prescribe short-acting beta agonists to people of any age with asthma without a concomitant prescription of an ICS of an inhaled steroid. So I guess the implication for prescribing teams is we should be reviewing patients' asthma. We should be looking at records to see if there is anyone who's still on a short-acting bronchodilator on its own and have a diagnosis of asthma, and we should be inviting them in for a review. Is that fair?
Agree. I think it's also a move away from SABA generally. So even if you are on an air or MART regime, just to be clear that you shouldn't really be using the SABA alongside. So I think overall we want to reduce the reliance on the prescribing, and so it's that conversation with patients. So in terms of the implications, I guess it's really having those quality conversations with patients. So that means that healthcare professionals themselves will need to be familiar with the guidelines and invest a little bit more time to spend having those discussions with patients, because patients may have read things, they might have been asked to come in for a review. And also we want them to feel more in control of their disease as well. So not that they're feeling that we're taking something away. So it's really that discussion, that shared decision making, and like you're saying, it's about risk stratifying as well, because there may be people who have an incorrect diagnosis. There may be people who have been prescribed a SABA and it's not really clear what that was for. So actually what we have here with the guidelines is an opportunity to do better.
Yeah, no, I completely agree with that, and it worries me as well that people will see this as it does still require that review, I think, and that conversation with the person to explain why NICE are making this NICE sign BTS are making this recommendation. Please, guys, don't just send letters out to people saying we're stopping your blue inhaler. It worries me because this still requires a bit of effort and making sure that it's person setting this. This is a great opportunity to do a review of their asthma as well, of course.
Then I was just going to say one of the things that we say as NICE associates is that these are guidelines, not tramlines as well. So really is that personalising it to the individual and what their perceptions are and what their reality is as well. So it's really, again, person-centred.
Yeah, I mean, I think diagnosis is really important. We know far too many patients who are on asthma registers do not have asthma. So, and people, because they've been prescribed salbutamol, doesn't mean they've got asthma or even a respiratory disease. We know a lot of people are given salbutamol for breathlessness, which may not even be an underlying respiratory condition. So I think we need to take that step back. I think you're absolutely right, Jonathan. We should not be just doing this by any sort of letter review, AQRX or anything like that. We should be bringing the patient in. We should be reviewing that diagnosis. And actually, this isn't just about the implementation of NICE. This is going back to the basics and ensuring that actually our healthcare teams and our patients understand exactly what asthma is. Salbutamol, terbutaline, do not manage asthma. They do not treat the condition, they just treat the symptoms. And what we need to do is ensure that we have a treatment that resets patients' immune system, that actually treats asthma. And of course, the cornerstone treatment of that is the inhaled corticosteroid. And that is the main treatment for asthma. And using it in combination with formoterol gives patient that short-acting relief that they want, but also that longer acting relief to actually to keep their airways open. So we have to do that education piece very much with our patients as part of that, decision with patients to switch to this regime, and give them that confidence that this inhaler will work as well as their short-acting beta and actually better, because it will prevent them from having exacerbations, prevent them from having symptoms, and may mean that they can do the things they want to do that at the moment they say I can't do because I've got asthma.
I think once you've explained that to people as well, they're much more likely to then adhere. Is probably not the wrong word, but to take their medicines in the most effective way. Once that rationale has been explained to them as to why we're doing this, why we're saying this.
It's also important to address patient concerns, which they may not voice, but actually people are worried. They have a negative perception of what steroids are and mean, so we want to have good disease control, and that would be using an evidence-based therapy, which includes the inhaled corticosteroid. And by using that regularly or as per the relevant regime for the patient, you're able to have better disease control, which then would minimize the exacerbations and flare-ups, which then ultimately end up on a patient needing oral corticosteroids. So it's separating out what's oral and inhaled, but also we want to limit that cumulative exposure. So I think explaining that and normalizing it and really putting their concerns into context as well, so that they're minimized. And the other thing that we haven't mentioned is that mostly the ICS LABA with the formoterol is a dry powder inhaler, so it might require a different conversation around inhaler technique. Now, the best inhaler is the one that the patient can use. So in terms of what's going to suit the patient's ability to inhale and what they can manage in terms of dexterity and coordination, if it is a dry powder for them, then that's great, and that's a better option. Also, it has less environmental impact as well. But really, as Anna has said, think about all the kind of the basics, the essentials as well, and then account for and address any other reasons for inadequate control before you are escalating therapy. Think about any comorbidities, anything else that might not be asthma or in addition to asthma that needs to be addressed as well. So actually, again, I think this is opportunities all round to consider a conversation around lifestyle. Some patients may be slightly overweight, and that might be contributing to breathing difficulties as well. So it's the opportunity to see how we can make things better for patients all round.
Yeah, we talk about failure demand quite a lot on this podcast and in other podcasts, such as the Oral Apothecary, whereas not doing something right in the first place leads to a whole bunch of extra work, probably for somebody else down the line. This sounds to me like a really, really good opportunity to make sure that person-centered care is at the heart of this, that the inhaler is appropriate to the person can use that inhaler. There is a preference sensitivity here as well. Some people like certain inhalers over others, but as you say, Ravijyot, the inhaler that has the least benefit for the planet and the environment and is the least sustainable is the one that isn't used or the person can't use, and then ends up having an exacerbation and ends up in hospital, costing the NHS loads of money, but also having a sustainability impact there as well. Just to go back to what you were saying before then, Anna, about the other changes in the guideline. You mentioned about diagnosis. What are the big changes around the diagnosis of asthma then?
Yeah, so like I said, diagnosis, unfortunately, with asthma perhaps hasn't been as good as it could have been. As I said, there's quite a lot of patients with incorrect diagnosis, and that obviously increases costs, both from sort of medication and also for the patient as well in terms of using inhalers. So the main things we've done is ensured that structured clinical history is probably 90% of the diagnosis of asthma. So making sure that you know, when you're asking patients about their asthma, you're asking the correct symptoms, you know, shortness of breath, chest tightness, coughing, particularly at night, which is the dry cough. Have they got any symptoms of atopy, you know, so eczema, hay fever, family history of asthma, because we know that if one parent has asthma, there's probably a 1 in 5 chance the child will get asthma. If both parents, it's probably 3 out of 5 are more likely to then develop asthma. So there's a real strong sort of genetic link there as well. But as Ravijyot said earlier, it's also then making sure that you've got this very good structured history, but you confirm that with objective tests. And the first for sort of adults or 16 and over is actually to look at blood eosinophil counts to see if they've raised. We've got to remember, like I said, you know, your immune system in asthma is overactive. You end up often in most types of asthma with eosinophilic airways disease. So you can look at blood eosinophil count, and that can give you a marker that this potentially could be asthma. If you've got FeNO, so exhaled nitric oxide, you can look at that, and that could be again indicative of a patient having inflamed airways. That very much correlates with blood eosinophil counts. And then if you can't use either of those, then there is obviously sending patients for bronchodilator reversibility, and then if that isn't clear, then sending patients on for sort of methacholine mannitol challenges, which is the propagation challenges. So there are that's really sort of the setup in sort of 16 years and over, and then in the children it's very much relying more on FeNO and your clinical history and reversibility.
So there's that mixture of sort of well, not quite subjective, but how are you feeling, how are you getting on, describe your symptoms with an objective test, with potentially measure of eosinophil count or FeNO testing as well to support that. So yeah.
In addition to that, the other thing is that all these tests they're all complementary and they're confirmatory. So it's not just you just do one and that's it. And if there is any doubt, you are building and adding, and they're all things to just further give you a really tight diagnosis. There may be a smaller proportion of patients where it's not as easy. So that's when you work through the different options, and it may end up, as Anna has said, that you then require a bronchial challenge. And so you refer for a test accordingly, which might be histamine, methacholine, etc. As well. I think the other thing that's stark and stood out for me is that the move away from routine peak expiratory flow monitoring. So previously, if you were suspecting asthma, you might say to a patient, do a peak flow diary for a couple of weeks. So that's, you know, we're not looking at peak flow as our mode of monitoring. It has a small role in the diagnosis if you don't have access to spirometry, for example. So there's less focus on the peak flow.
And presumably, as well as diagnosis, you've got so initial diagnosis, but then you've got ongoing monitoring, haven't you, of control? So presumably there is implications there for how you go about monitoring asthma control at asthma review meetings.
Yeah, I mean, you would carry on, Jonathan. Most people are quite familiar with using the asthma control test, the ACT. Yeah. So I think you would carry on still using that. I would always encourage, you know, monitoring adherence, so looking at how many prescriptions patients have picked up. And I think that for me is extremely important also with AIR and MART, is to ensure that patients aren't overusing their treatment. So they've been quite familiar with overusing their salbutamol. Now, they shouldn't do from a clinical perspective, but they might still be doing that, or they might have really bad disease and be requiring to use more or poor inhaler techniques. So there's lots of things that would also pull up. So that still should be very much part of the monitoring of your patient, as well as you know, monitoring their control.
Good reminder of patients who aren't controlled, despite all the optimization and correct interventions, that they might require further specialist workup and potentially other treatments as well. So it's making sure that those patients are identified earlier, and there's again a pointer towards the AAC uncontrolled asthma pathway. So that's a really useful pathway for people to refamiliarize themselves with, to ensure patients get referred for specialist care as well.
So just to finish off, guys, in terms of what do you think the three take-home messages would be for primary care-based clinicians from this update? Ravijyot, do you want to tackle that one?
Yeah, so I've mentioned the AAC pathway, so just making people aware of primary care that's there. It's a really useful pathway to refer to. So if they're unsure of what to optimize and how to do that in the first instance, it gives you some pointers. But I think it's really important always to have a follow-up after a change in therapy to make sure there's been no inadvertent destabilization of disease as well. I think another tip would be, and the guideline is clear about observing inhaler technique as well. So whilst we've got lots of virtual appointments and there's a role for them, I think we need to be mindful of that and not do a review over the phone. So you can't observe the inhaler technique if the patient's not in front of you, or if you've got a video appointment as well. So I think, there are lots of pressures in primary care, but just making sure we're able to be a little proactive and start to stratify and find some of these patients who are maybe on incorrect therapy, don't have a diagnosis, it's not clear, etc. So yeah, everybody's really busy, but there's some key things that they can do to make even more impact.
Yeah, it goes back to that failure demand thing again. If we don't get this right, it just creates more work for you and others in the longer term. So yeah, it's a good opportunity to do that.
Yeah, just on the virtual review, I totally agree. You cannot check an inhaler technique and optimize it without seeing the patient face to face. But saying that, if you are doing a virtual review, don't ignore the fact they're on an inhaler. You can still talk through good inhaler technique, and you can still send them and redirect them to like the Asthma and Lung UK videos and things like that. So there's still things that you can do. And I think it's important that we always confirm, check, talk through inhaler technique with patients and make them appreciate that inhaler is such an important part of their medicine. The only other thing I wanted to add, perhaps for take-home message for primary care, is really the place of air and MART. And I think there's a little bit of confusion, Jonathan, of when patients are on air, when patients are on MART. I think air is for patients with very, very mild asthma, where they can just use it sort of when required and as their symptoms are very variable. But if you do start to have patients who are more symptomatic, then you should be starting more on the MART therapy. If you've got patients who perhaps have very little awareness of what their symptoms, don't recognise bronchoconstriction, then they should probably be on MART and not air. I think if they have any sort of severe exacerbations or history of life-threatening asthma, then we should be using MART therapy rather than air. And that is actually documented within the NICE guidance as well. So I think we just need to be careful that we don't have all our patients just being told, oh, just use it whenever. For some of our patients, we will need them to be on maintenance and reliever therapy. And the AIR studies, the Sigma 1 and Sigma 2, were really just 12-month studies. So we do need to be a little bit careful about where we implement that.
Yeah, no, I think that's a really, really good point, and one that's easily missed, I think, Anna. In terms of take-home messages for hospital colleagues who might be listening, Anna, what would you say the three take-homes for hospital colleagues would be?
So I think to be updated yourselves on the new NICE guidelines, to make sure that's across the board. So patients coming into A&E, people coming into any admissions unit are very, very aware of the guidelines and prescribing accordingly. There's nothing worse than patients being changed from one regimen to another just when they come into hospital. To make sure on that note that prescriptions are very clear on TTOs, that perhaps we also as pharmacists use the discharge medicine service to inform our colleagues in community pharmacists if we are changing prescriptions or making them aware of what's going on. If patients are coming in for an acute asthma exacerbations, think actually, is this patient actually eligible for more advanced therapies, and do they need to be referred through to a tertiary centre for initiation or consideration, should I say, of biologic treatment? But actually, a lot of the time people get admitted because they're not using their inhalers correctly, either inhaler technique or adherence. So sometimes even when people come in, check and go back to the basics. If you can access primary care records, what have they been collecting? How adherent are they? Don't just step up treatment and add more in. Think, actually, can we just educate? This is an opportunity to improve the care whilst you've got that patient in hospital with you.
No, I completely agree with that. The thing that's coming across to me is that the opportunity that's here that this guideline update gives us in primary care, but also in hospital hospital care as well. If someone's come into hospital with an exacerbation, that's a really, really good opportunity to make sure they've got the basics right in the first place. And that again will potentially save a whole lot of time and effort down the line.
Can I add in a couple of points if that's all right, Johnny?
Yeah, yes, of course.
So, I mean, as Anna has said, I think it's important to get the maximum bang for buck. So we can do that when people have come into a hospital, and depends whether it's a pharmacist, another colleague, and pharmacists are great as detectives, and we do look into histories and medicines reconciliation. So I think it's an opportunity to get a steroid history as well, and just make sure that patients aren't having lots of courses of steroids, because oral steroids as well, and how they're using their inhaled steroids. So that's good to kind of look in terms of that. And also we want to treat the patient, not a number as well. So the guidelines do say look at eosinophil levels and FeNO readings as well, but we want to put those into context with what's been going on with the patient. So were they on prednisolone at the time? So if we're looking at eosinophil levels, etc. as well. So yeah, it's like Anna said, it's that opportunity to link in with our other primary care colleagues, including community pharmacists who do lots of work and do some of these reviews and have conversations. So it's really empowering them and linking up and having a better kind of network of people as well. So I think that's my tuppence there.
Fantastic, thank you very much for that, Rajijyot. Thank you, Anna, as well. Thank you both for your wisdom on this. It's really, really helpful. I'm sure listeners will find it really useful. So cheers, guys, and we'll see you next time in a fortnight for the final episode of Sensible Prescribing in Older People with Jonathan and Lucy, and we'll be talking about the use of statins in older people. See you there. Bye.